So I request technical support to please start the recording session as we are starting the lecture soon. So it's 8:02 already. We should start the lecture. I think let's start. So respected dignitaries, esteemed teachers, dear colleagues, and all participants, a very warm welcome to each one of you. On behalf of NEMA OBGY Society Central, I, Dr. Aarti Kulkarni, coordinating this webinar, that is number 88 in our academic series. Today's webinar is organized by NEMA OBGY Society Central, and the topic of today's webinar is hyperprolactinemia, a practical approach in OBGY practice. So it gives me immense pleasure to introduce today's esteemed speaker, Dr. Abha ma'am, Dr. Abha L. Ravi. She has completed her BMS from A.L.N. Rao Memorial Ayurveda Medical College, Koppa, Karnataka. She pursued her post-graduation MS in Sero Prasuti Tantra from the Government College Ayurveda College, Tiruvananthapuram. Currently, she is serving as professor and HOD of the Department Srirog and Prasuti Tantra at Mandsaur Institute of Ayurveda Education and Research, Madhya Pradesh. She has actively contributed to academics and research as a resource person in national seminars and webinars. She has presented research papers, published articles in reputed journals, and she has also worked as a peer reviewer. Dr. Abha has vast clinical experience in managing gynecological disorders through pure Ayurveda treatments, including fibroids, PCOS, and various other gynecological conditions. She has also successfully treated more than 20 cases of infertility, reflecting her strong clinical expertise in reproductive health. We are truly privileged to have such an experienced academician as well as clinician with us today. So without taking much time, I humbly request Dr. Abha ma'am to kindly begin her lecture on hyperprolactinemia, a practical approach. Over to you, ma'am.
Thank you, ma'am. Thank you for a nice introduction. Namaste all. Chadurmukha Samarambham Vakpadacharya Madhyamam Asmadacharya Paryandam Vande Guru Parampara. Paying salutation to the Almighty and my great gurus. Today I am going to present hyperprolactinemia, a practical approach, the condition which significantly affects the reproductive health, metabolic balance, and quality of life. Moving on to the slides. The points to be discussed: a brief about the anatomy of pituitary gland, understanding prolactin, possibilities and causes of hyperprolactinemia, clinical features, management approaches, and Ayurvedic balance. First, about the pituitary gland. The pituitary gland, the master gland or hypophysis, is an endocrine gland located at the base of the brain, protruding of the bottom of the hypothalamus. As we know, it has two lobes, anterior and posterior lobe, that is adeno and neurohypophysis. The anterior lobe regulates the growth, metabolism, stress response, reproduction, and lactation. And the main hormones from the anterior pituitary are growth hormone, thyroid stimulating hormone, adrenocorticotropic hormone, prolactin, follicular stimulating hormone, and luteinizing hormone. And from the posterior lobe, oxytocin and vasopressin. Then coming to prolactin, unlike the other FSH, LH, prolactin, anyway, all the hormones are polypeptide in nature, but this prolactin is a polypeptide hormone which is structurally similar to the growth hormone and human placental lactogen. This is exclusively synthesized and secreted by the lactotrophs in the anterior pituitary. The primary function of prolactin is to enhance the breast development during pregnancy and lactogenesis. It affects reproductive health, immunity. It's an immune modulator. It stimulates the antibody production in the body, and it influences the metabolism, and it helps in the osmoregulation by maintaining the body fluid balance. So just like the gonadotrophin releasing hormone, the secretion of prolactin is also in pulsatile manner, and it varies. So there is a diurnal variation is there. This is very significant thing to consider because the prolactin, which increases during sleep, and reaches its peaks around 5 to 7 a.m. and then comes down and it gets into its normal level by 8 to 10 a.m. So while checking the prolactin level, it is better to go for the timing 8 to 10 a.m. At that time, the normal level of the prolactin will be available. Then about the hypothalamic control of prolactin secretion. So GnRH secretes from the hypothalamus, stimulates the FSH, LH, everything is stimulatory in nature, whereas the prolactin from the anterior pituitary is under inhibitory action of the hypothalamus. The hypothalamus from the arcuate nucleus and paraventricular nucleus of the hypothalamus, there will be production of dopamine and it tonically control the secretion of the prolactin. So the prolactin is under tonic inhibitory control of the hypothalamus. Then about the regulation of the prolactin secretion, what are the factors increasing the secretion? First one, prolactin releasing hormone. The next one is the thyrotrophin releasing hormone. So this directly influences the lactotroph in the anterior pituitary and stimulates the secretion of prolactin. Then estrogen has a positive effect on the prolactin. Breastfeeding. By breastfeeding, there will be stimulation of the sensory nerves of the nipple and it transmits the stimuli to the spinal cord. From there via vagus nerve. The stimulation reaches the arcuate nucleus and paraventricular nucleus and it enhances the production of prolactin from there. Then stress. Stress has a positive impact on the prolactin secretion. And of course, sleep. By sleeping, the prolactin level increases. Then chest wall trauma. Again, stimulate the vagus nerve and there will be excess production of prolactin from the anterior pituitary. Then other factors increasing the prolactin secretion are dopamine antagonists. So which act against the secretion. We know the dopamine is the controller of the prolactin secretion. If the drugs like antidepressives, some antihypertensives, antipsychotic drugs, these all acting as dopamine antagonists, that is acting against the dopamine, so which also increases the prolactin secretion. Then oxytocin also has a stimulatory effect on the prolactin secretion. So while breastfeeding also, the sensory stimuli along with there will be oxytocin secretion also, both together increases the secretion of prolactin. Then about the factors inhibiting the secretion. So obviously the dopamine and dopamine agonist. Dopamine agonist like bromocriptine or cabergoline. Then we will discuss about what is hyperprolactinemia. So when the serum prolactin concentration exceeds its threshold level, then we will call it as hyperprolactinemia. So this can happen in any condition that alters the prolactin secretion or clearance. Anything, either the increased secretion or the clearance, especially the metabolism of the prolactin taking place in the liver and the clearance through kidney. So chronic kidney failure also leads to the increased prolactin level in the body. So the normal level of prolactin ranges from 5 to 20 nanogram per milliliter and the level above 20 nanogram is considerable. So the hyperprolactinemia can result from physiological, pathological or it could be drug induced. Coming to the physiological conditions. So the physiological conditions are transient in nature. So first one is pregnancy and lactation. So in pregnancy, there will be hyperplasia of the lactotroph cells and the pituitary glands doubles in its size. So there will be increase of prolactin secretion during pregnancy and reaches its peak in the term and then gradually declines. And during lactation compared to the pregnancy stage, the level of prolactin is less. But when there is a nipple stimulation while feeding, there will be a surge of prolactin from the anterior pituitary. Of course, nipple stimulation, as I already said, the nipple stimulation stimulates the sensory nerves, and in turn it stimulates the vagus nerve, and via there will be increased secretion of the prolactin due to the activation of activate nucleus and paraventricular nucleus of the hypothalamus. So this, if there is a stimulation of activate nucleus and paraventricular nucleus of the hypothalamus, there will be obstruction of the action of dopamine, and like that, it will increases the secretion of the prolactin. And then chest wall stimulation, sleep, stress, and exercise also found to increase the, but these all things are transient or temporary in nature, the physiological factors that are affecting or that are leading to the hyperprolactinemia. Then coming to the pathological factors causing hyperprolactinemia, first and very important one is the primary hypothyroidism. So in primary hypothyroidism, the thyroid gland is inefficient to produce enough thyroid hormones. So there will be lacking of enough thyroid hormones in the circulating blood. In turn, it stimulates TRH. As we know, TRH, thyroid releasing hormone, has a positive effect on the prolactin secretion. It acts on the lactotropes and increases the secretion of the prolactin. Then prolactinomas. Prolactinoma is the benign tumors of the pituitary gland which secretes prolactin. So usually these are the benign tumors. Then any other tumors of the hypothalamus or tumors of the pituitary stalk. So these tumors of the hypothalamus or pituitary stalk, this will compress the tract. So there will be obstruction of the action of this dopamine. So even though there is a normal secretion of dopamine, there will be obstruction in the pathway. So the dopamine cannot reach the target tissue, and so it won't act on the secretion of the prolactin, and there will be excess secretion of the prolactin from the anterior pituitary. So then the chronic renal failure, as I already said, the clearance, there is a hampering in the clearance of the prolactin from the body. So normally the prolactin is excreted via urine through kidneys. So here the prolactin clearance is not taking place, leading to hyperprolactinemia. Then next is the drug-induced hyperprolactinemia. So usually the drug influencing prolactin levels are estrogen therapy, antipsychotic drugs, then antidepressants, antihypertensives, anticonvulsants, and there is a list of medicines that affects the prolactin or increases the prolactin secretion or hampers the dopamine receptors in the body. Then how the clinical presentation will be. So the increased prolactin level affects both male and females. So in females, usually it affects the the ovulation, and it affects the normal menstrual cycle. So manifest as menstrual irregularities, infertility, whereas in male, it affects it as sexual dysfunction. So in females, there will be menstrual disturbances because this increased prolactin will stimulate the kiss peptin in the hypothalamus, which in turn decreases the secretion of gonadotropin releasing hormone. So if there is no enough gonadotropin releasing hormone, the secretion of the gonadotrophins, that is FSH and LH, will get hampered. So there won't be proper steroidogenesis from the ovary. So ultimately it results in ovulatory dysfunction manifesting as oligomenorrhea, amenorrhea, or heavy bleeding. So if there is ovulatory dysfunction, there may be irregular periods, and when she gets periods, there may be heavy bleeding. So these all symptoms depends upon the level of this this obstruction. Like if there is a mild obstruction, the manifestation will be lack of follicular development. But if the manifestation is moderate level, then it will manifest as oligomenorrhea with heavy bleeding. But if the suppression of hypothalamus, like GNR suppression is at high level, the lady will manifest as amenorrhea, complete absence of menstruation for a period more than 6 months. The next manifestation is galactorrhea. So galactorrhea is the milk synthesis outside of lactation. But it is not mandatory that those having hyperprolactinemia will be having galactorrhea. This is because for the milk secretion, not only the prolactin or prolactin alone is not sufficient. There are some other factors which requires for the proper milk secretion, like estrogen primed breast lobules and ductals. That is, if that estrogen priming is not there, like if the gonadotrophin release is very much suppressed, and there is the improper steroidogenesis from the ovary, which in turn cause the lack of estrogen and progesterone. So in that condition, there may not be galactorrhea. So those who have hyperprolactinemia may not have the galactorrhea. Usually, in 1/3 cases, the galactorrhea can be found. In children, it can lead to growth arrest, delayed puberty, or primary amenorrhea. And of course, if there is improper ovulation, the lady may manifest infertility. And in males, so there will be signs of hypogonadotrophic hypogonadism. So the sexual dysfunctions will be in the form of decreased libido, infertility, impotence, oligospermia. Gynecomastia is very rare actually. And erectile dysfunction, not gynecomastia, galactorrhea is very rare in males. Then low bone mass. Then how to evaluate the hyperprolactinemia? So when a patient comes, there are two possibilities for the presentation. First, the patient comes with the clinical features of the hyperprolactinemia, or there may be patient asymptomatic and accidentally or incidentally diagnosed with the hyperprolactinemia. So if we get a report with a high level of prolactin, that with the hyperprolactinemia level above 20 nanogram per milliliter, so first thing should come to mind, like as the prolactin can vary, like with there is a diurnal variation or a physiological condition. If there is even some breast examination also, that is very important to remind. Like if we are going to evaluate the prolactin, better to avoid the breast examination prior to the evaluation of prolactin, because that can in turn increase the prolactin secretion. So it is better to avoid breast examination prior to the prolactin evaluation. So as it has a diurnal variation, rechecking is mandatory before the confirmation of diagnosis. So the main points to note are, first we are checking the serum prolactin level. So the timing is very important. Better to check the serum prolactin in fasting level, and better timing is mid-morning, that is around 8 to 10 a.m. or maximum 11 a.m. So we should not check at the around 7 or 8 before 8 a.m. because the level will be higher than normal. Then exclude the secondary causes like physiological causes or pathological causes and the drug-induced causes. All these things we should exclude. And then pituitary imaging. So pituitary imaging in the form of MRI, but it is not at all mandatory in all cases of hyperprolactinemia. So if we found a patient with the serum prolactin level more than the normalcy, that is more than 20 nanogram per milliliter, then we need to first inquire about the menstrual history. So first we need to ask about the menstrual history. If the lady is having, if the lady is having irregular menstruation or any other menstrual abnormalities, then we need to ask about the other, we can correlate with that condition. If she is not having any other problems like no history of drug intake, or if there is no hypothyroidism, so excluding all other factors, and if the prolactin level is found to be increased, then only we can go for the MRI. Otherwise, the MRI is not a mandatory thing. Then the key diagnostic considerations. So first one is the serum prolactin measurement, as I already said. Then if the prolactin level found to be increased than normalcy, then we have to definitely we have to go for the thyroid function test, because in almost all cases of increased serum prolactin level, thyroid function test, there is a high chance for hypothyroidism, especially primary hypothyroidism. So in that case, we need to go for the thyroid function test. So if the thyroid function test found to be normal, then we need to exclude all the secondary causes like physiological causes like nipple stimulation or feeding or chest compression or pregnancy or lactation, and then the pathological conditions like kidney failure or any other these conditions, and then the drug induced like any intake of hypertensive, I mean like methyl dopa or like anti this convulsants or like that medication should be excluded from the course. And then we can go for the pituitary images to find out whether any tumor or adenoma in the pituitary. Then the main one more point is the hook effect. So it's otherwise known as prozone effect. It's a laboratory finding, that is the wrong finding in the laboratory. If the prolactin level is very much raised, it may affect the antigen reaction in the immunoassay, and it will affect the antigen antibody complex, and it will give a the reports will be like normal or less than normal with the patient with a high level of prolactin. That is, actually the patient will be having hyperprolactinemia, but due to this faulty laboratory calculation, this is due to the higher level of prolactin hampering the antigen reaction. So the result will be getting as more less than normal or normal, but actual will be, the level will be higher. So in this case, we need to repeat investigation because the patient may be showing the symptoms of hyperprolactinemia, especially if there is space occupation lesion impact, like if the patient is having headache or visual disturbances, definitely we have to repeat or we have to go for higher investigations. Then macroprolactinemia is another one condition. Macroprolactinemia is a complex of prolactin and immunoglobulin G. So this is actually biologically inactive form of the prolactin. But in the prolactin assay, we will get the value as raised because the macro size of the prolactin. So why we need to investigate this is to avoid the unnecessary interventions. So if macroprolactinemia is suspected, if the patient is having a higher level of prolactin with without any clinical symptoms, and if the patient is not reacting to the dopamine agonist therapy, then we have to suspect the macroprolactinemia and to go for further investigations of to find out the macroprolactinemia. This I have already discussed. Like if we get a serum prolactin level found increased, then we should inquire about proper menstrual history should be taken, inquire about the menstrual pattern, quantity and all. Then ask about the history of galactorrhea, that is milk secretion from the breast other than the lactation period. And then physiological causes should be inquired. Drug history, detailed drug history should be taken. Symptoms of hypothyroidism should be checked, and any symptoms of space occupying lesions, especially if there is a tumor compressing the optic chiasma. So there is chance for visual disturbances, and if there is a compression, there will be headache for the patient. And if the lesion of compressing the pituitary stalk, it will hamper the flow of dopamine. So definitely there will be increase in the prolactin level from the anterior pituitary. Then about the modern management. So the line of management is treat the cause and treat the symptoms. So find out the cause. There may be multiple causes for the manifestation of the hyperprolactinemia. The cause may be in the pituitary level, like it may be a tumor. It may be an infiltrative condition like suppressing the pituitary stalk like TB even, or it may be hypothalamus tumor, or maybe physiological cause or pathological causes like kidney failure, or it may be drug induced. So the causes will be or hypothyroidism even. So it's a very important cause is a hypothyroidism. So find out the cause and treat accordingly is the main thing. And second one is to treat the symptoms. So the patient may present with multiple symptoms. Sometimes she may be complaining of infertility, sometimes irregular menstruation, sometimes galactoria, sometimes headache, visual disturbances. So according to the symptoms, we have to rule out the condition and treat accordingly. So if there is an offending drug intake history is there, the management should be given accordingly. That especially if antipsychotic drugs and all, the patient may be under continuous intake, and sometimes it may not be possible to change the medicine even. So then we may need to add dopamine with the drug like bromocriptine or cabergoline should be given along with that antipsychotic drugs. So accordingly, the management should be modified. Sorry. So next, how to manage the symptoms. So it depends whether the patient is desirous of fertility or if in case if she's not desirous of infertility, the management varies depends on that. So if she is not desirous of fertility, sorry, if she is desirous of fertility, it's a mistake. If she is desirous of fertility, oral contraceptive, no, sorry. So if she is not desirous of fertility, oral contraceptive pills can be given to regularize the menstrual cycle and hormone balance. But if she is infertile and she wants to conceive, then ovulation induction can be given with gonadotropins, and then dopamine agonist can be given. So dopamine agonist in the form of bromocriptine or cabergoline. So the effective form is the cabergoline. Bromocriptine anyway, it has some side effects also. So ovulation induction with the gonadotropins here, because the clomiphene citrate may not be effective in cases of hypogonadotrophic hypogonadism where the estrogen progesterone level will be very less. So in that condition, better to give the ovulation induction with the gonadotropins, and dopamine agonist like bromocriptine or cabergoline if we are giving. So that will regularize the secretion of gonadotropins from the hypothalamus. That is gonadotropin releasing hormone from the hypothalamus. In turn, it corrects the hypothalamo-pituitary ovarian axis. And if there is a prolactinoma, so then we have to check for the visual field defect. Especially the peripheral vision will be affected in such cases. And then the medical management, especially with the dopamine agonist. So, and coming to the surgical management of hyperprolactinemia. So, of course, the first line of management is medical itself. But if the patient is unresponsive to the medical management, or if there is a persistent visual defect or headache, like that indicates the space occupying lesions like tumors, in that case, we have to go for the surgical management. And the preferred surgery is endoscopic endonasal transsphenoidal surgery. And if the lady is having a large prolactinoma and it may have a threat of vision during pregnancy, in that cases, prophylactic surgery can also be done. And in case of residual tumor, adjuvant radiotherapy can also be done. And if the prolactinoma is resistant to the dopamine, in that case, gamma knife stereotactic radiosurgery is advised. So in a nutshell, so the patient diagnosed with hyperprolactinemia, so the clinical presentation may vary. So there are two chances the patient present with hyperprolactinemia. There may be or may not be clinical presentations. So if the patient is not having clinical presentations, we have to go for the confirmation whether it is a macro prolactinemia, or if all the conditions are normal, the final diagnosis will be idiopathic hyperprolactinemia. But if the patient is having clinical presentation, the things will be variable. First, we need to rule out the drug intake, then rule out the space occupying lesions through the imaging techniques, and check for the primary hypothyroidism. And the management should be given according to the cause and symptoms. So the management varies depending on whether the patient is desired for future conception or not. So these are about the modern concepts and management about the hyperprolactinemia. Then coming to the Ayurvedic reference. There is no direct reference in Ayurveda about the hyperprolactinemia. So, do all diseases needs to be named? Is that mandatory to name all the disease? What is your idea? So this is a reference from Charaka Sutra 18th chapter. Vikaranam akushalo na jihniya kadachana na hi sarva vikaranam namado asti dhruva sthidihi. Sa eva kupido doshaha samudhana visheshadaha sthanantara gadaschaiva janatyamayan bahul. Tasmat vikara pragadir adhishtana antaranicha samudhana visheshamsha buddha karma samachari. So, for a wise physician, if he is unable to name a disease, it's not a matter to be get ashamed, because no, it's not possible to name each and every disease, because based on the dosha prakopa, based on the origin, samuthana vishesha, sthana, everything. So there is innumerable manifestations of diseases. So it is not mandatory that we should name a disease and accordingly we should manage. So based on the vigara prakriti, adhishtana and the samudhana vishesha. So based on the dosha prakopa, samudhana, that is the origin and nature of the disease, we have to plan the treatment based on our yukti. That is a reference from Charaka Sutra. So it is not at all mandatory to name a disease. So, considering hyperprolactinemia, as we know, the condition is multifactorial in nature. There may be innumerable factors behind the manifestations. It could be a physiological factor, it could be a pathology. One hidden pathology will be there, or a history of drug intake will be there. So, we have to find out the nidana of that. Identification of exact nidana is very essential, and then followed by the Nidana Parivarjana. So appropriate Ayurvedic treatment can be planned after determining the underlying factors. So, as we know, Rasa, Stanya and Artava are the Ubadhadus of Rasa. Rasa, Stanyam, Artavam Cha. So, the Rasa Dhatu, which is the first Dhatu formed after this Jadarakni Samyoga with the Ahara. So the Stanya and Artava. So from the Saumya Guna Yukta Rasadhadu, the two Ubadhadus which are formed, first one is the Saumya Guna Bhuvishta Stanya, and the next one is the Agni Guna Bhuvishta Artava. So in that commentary, Chakrapani is mentioning like this is the Prabhava something acting over there. So that from the Saumya Guna Yukta Rasadhadu, the Agni Guna Bhuvishta Artava is formed. So in a non-pregnant stage, as we know, each and every thadus of our body, each and every cells of our body has its own metha. Thi, Thridi, Smriti is hidden in all the cells of our body. So there is some Thi Vipramsha in the Rasadhadvagni level affecting the guna change, I feel. Ki Rasadhadu, that is turning into Stanya. So the Rasadhadu Agni is determining when to produce this Saumi Guna in that byproduct, or when to increase the Agni Guna in that byproduct of Rasa. So as we know, if the Saumyamsha is increasing, definitely the Artava will get hampered. So because Artava is Agni in nature. And already Acharya he explained like Roga Sarvepi Mandagni. All the diseases are happening due to the Mandagni. Mandagni indicates the improper functioning of the Agni is responsible for all the manifestations of disease. So based on the Agni level, we can manage any condition, especially the female disorders can be managed based on the Agni, because Artava, Stanya, all the things are from the formed from the Jadaragni. That is, if the Jadaragni is proper, the Uttara Dhatu Nirmana will be definitely normal. So the line of management, if there is a prolactin secretion is excess, the Stanya Kshapana and Artava Janana Chikilsa can be adopted in case of hyperprolactinemia. As we know, Artava is Agni in nature, so to increase the Agni Amsha, already Sushrutacharya said like Doshi Ravrita Margatva Artavam Nashyadi Striya. So Doshi Ravrita Marga here the dosha indicates the Vada Kapha. Vada Kapha Vrita Margatva Apravrittamana. That is the Vada and Kapha is obstructing the channel. So Vada Kapha, wherever the Vada Kapha is there, there will be a Grandhi formation. In Grandhi Ulpati, we are considering the dosha predominance as Kapha Vada. So we can correlate all this with the tumors, prolactinomas, anything that is hampering the proper secretion, proper flow of dopamine from the hypothalamus to the pituitary. So, doshi ravrita margatva. The marga is obstructed, hampering the pituitary secretion, can be correlated. Doshi ravrita margatva, the artavam nashyati. There the artava nasha is explained. Anyway, we know if the prolactin level is more, of course, artava nasha is there. I'm not, this can be explained in another way. In this context, I am correlating this with the hyperprolactinemia. Otherwise, this Artavaha Strodo obstruction is also can be correlated. But according to the condition, I am correlating the term with the hyperprolactinemia. Then Tatra Malsi Kulatha Amla Tilamasha Surahida, Pani Mutra Mudashi Sedadi Shuktam the Shuktam cha Pojani. So the line of management, the things which can be given, or the Agni to increase the Agni Tattva in the body, or to kindle the Rasadhadvakni, maybe. Tatra Malsi Kulatha Amla Tila, all the things which is hot in potency can be given. Malsya Kulatha. Kulatha is very good because it's Lekhana in action, Kapavadahara Legana Deepana. So Kulatha can be given as a drug of choice or drug preparations with a combination of Kulatha like Kulatha Kashaya, then Kanashadahwadi Kashaya and all. So Kulatha Amla, then Tila, Masha, Sura, then Pani. For the Pana Mutra, Udashit is a takra preparation. The takra, this curd added with water without removing the fat. So that is called Udashit. Dadi also and Shukta. So these all can be included in Bhojana. So we know Rasajana Vikaranam Sarvam Lenkhanam Aushadam. The prime treatment for all the rasa because we know Ardhava is Rasaja, Sani is also Rasaja. So all the Rasaja Vigaras, the prime treatment is Lenkhana. Because nowadays the diseases which are occurring is not due to the malnutrition but due to the malnutrition. Because going to the malls, having heavy foods and all are found to tell like I'm a foodie. They are feeling happy to tell like I'm a foodie. So food become a major problem to create diseases. So here the Rasajanam Vikaranam Sarvam Lenkhanam Aushadam, the prime treatment for the management of Rasaja Vikaras is considered as Lenkhana. So the line of management, we can consider it as Tatra Samshodhanam Agniyanam cha Dravyanam Vidhivat Ubhayoga. Samshodhana Karma. Here in commentary, the Samshodhana especially mentioned by Dallana mentioned like Vamana should be done, Virejana is contraindicated, but Chakrapani mentioned like both Vamana and Virejana can be done. And I feel compared to Virejana, in this hyperprolactinemia case, Vamana will works more. Even though Virejana is also good, but compared to Virejana, in this hyperprolactinemia, Vamana, because anyway the site of origin is Urdhvanga and it is Kapasthana and Vamana is the Agri Chikilsa for the Kapashamanartha. So the Vamana Chikilsa will be found to be very beneficial in case of hyperprolactinemia. Then Agni Anam Dravya, all the Dravyas which increases the Agni Tattva in the body can be used. Then for Stannik Shapanartha, the treatment principles mentioned like Tadha, Tesham, Yathasvam, Samshodhanam, again Samshodhana, Shapanam cha Kshayad Abhiruddhi Kriya Visheshi Pratigurveda. Like Kriya Vishesh in commentary, Dalana explain like Samshodhana, Samshamana, Ahara and Ajara. Then if we know the hyperprolactinemia is multifactorial in nature, so we have to find out, anyway, we need to find out the root cause. If the condition is due to some grandhi, like any tumor or any prolactinoma, so the management should be planned accordingly. So here we need to focus on the Deepana, Pachana, Lekhana and Kapavadahara. Of course, for the line of management of hyperprolactinemia, this is the line of management, Deepana, Pachana, Lekhana and Kapavadahara. So some ganas found to be beneficial like Mustadi Gana, Vajadi Gana, Haridradi Gana are found to be Vaja Haridradi Gana combination also can be given, and it's found to be beneficial in case of high prolactin level. But still, if it is not getting subsided, then what we need to do? Because then we can consider it as a Grandhi, and for Mamsaja Grandhi can be considered. So Samshuddhi Shastra Kshara Agni Karmasha, of course here Kshara and Agni Karma is not possible in case of tumor affecting hypothalamus or pituitary. So definitely we have to go for the Shastra Chikitsa, or the surgery is indicated if the patient is not responding to the treatment. Then use of Tikta Kashaya Rasa Pradhana Dravyas can be given because Tikta Rasa, again it is Deepana, Pachana, Lekhana and Stanya Shodhana in nature. So this property can be used. Even Tikta Krida, Tikta Kashaya, Padavaladi Kashaya, all these things. Because we know these Padavaladi Kashaya and all acting on the liver also, and this prolactin is metabolized in the liver. So in that way, the Tikta Rasa Pradhana Dravyas which will be very beneficial in case of hyperprolactinemia. And again, Kashaya Rasa, Tikta Kashaya Rasa predominant because Kashaya Rasa is Sangrahi and Shoshana in nature. So the rasas predominant with Tikta Rasa and Kashaya Rasa Dravyas can be given in case of hyperprolactinemia. Then Shodhana Karma, of course, especially Vamana and Nasya found to be beneficial. Nasya, of course, with an Antaila Nasya, or Varnadi Kshira Nasya, Varnadi Gana Siddha Kshira Nasya or Krida can be prepared, and with that we can give the Nasya. Varnadi Krida Nasya also it's very effective because Krida is the only one medium that can cross the blood-brain barrier. Then about the Pathya. As we know, Ahara Sambhavam Vastu, Rogascha Ahara Sambhavaha. So our body is constructed with the food body entity. No, what we take, we are. So, ahara sambhavam vastu, rogasya ahara sambhavam. All the diseases are also due to the ahara itself. Roga sarvaivi mandagno, or roga or manifesting due to the improper ahara viharas. So, we have to avoid Madhurya, Brahmana, Sneha, Shira, Gunayukta Aharas. So we know during pregnancy the Saumya Dhadu is more needed. So we are telling Navanida Kridakshire Sadacheno Ubajari. For pregnant ladies, we need the prolactin level more. Saumyamsha Artava should not be there, no? So the Saumyamsha should be increased. So we are indicating Madhurya Shita Drava Snikta Aharas, Madhurya Brahmana Dravyas, Snikta Shita Dravyas all. During pregnancy, at that time the prolactin level will be more. The Stanyamsha will be more. The Rasadhadu Agni is producing more Stanya. But in normal conditions, that should not be there. The Rasadhatu Agni should not lose its dhi to transform the Rasa Poshaka into Artava, isn't it? So, in that condition, if mother with, in non-pregnant stage, so we have to, if the prolactin level is high, that's the same, the Shidamsha is high, then we need to give Madhura Brahmana Sneha Shida Gunayukta Aharas. Sorry, we have to avoid this Madhura Brahmana Sneha Shida Gunayukta Aharas. Avoid all Kahavartaka Aharas. Kshira Vigaras, Manda, again it is Kapavartaka, and then Ikshu Vigaras also. So I feel whatever prescribed for Garbini should be avoided in case of this hyperprolactinemia. So this about a short presentation regarding the hyperprolactinemia. So with this, I conclude Ayurveda Amritana. Thank you. Thank you all for the patient listening.
Thank you, ma'am. On behalf of Nima OBGY Central, I sincerely thank Dr. Abha L. Ravi, ma'am, for such a clear, practical, and clinically enriching session. So your clear guidance on accurate diagnosis and the importance of precautions which has to be taken while testing the prolactin, that is proper timing, avoiding stress and breast stimulation and exercise and repeating doubtful values before labeling that hyperprolactinemia was truly a valuable and a very clinically take home message. So thank you for such meaningful and clinical insights, which are very valuable. So this integration of modern diagnostic clarity with Ayurvedic root cause management truly offers a holistic and patient-centered approach. So thank you so much for this wonderful lecture. So I think we'll now go ahead with the question and answer session. So I request all the participants to please put their queries in the chat box. We'll take one by one. I think there is one question by Dr. Smita Patil. So, is ma'am, please explain the role of Nasya, Varunadi Kshira Nasya.
Yeah, as we know, Nasa hi Shirasodwara. So we know the prolactin secretion is from the anterior pituitary. So the higher centers, the correction should be from the higher centers. We know the whole system of our reproductive is under hypothalamo pituitary gonadal axis. So we need to, anyway, the line of treatment, Ayurvedic line of treatment is to eliminate the root cause. So that's why the direct action towards the higher centers and the root is Nasya. That's why the medicaments are directly given to Nasya, because Nasa hi Shirasodwara. That's why. So that's why now Nasya is found to be beneficial and it's giving results also.
Yeah, ma'am, the preparation and the dosage and how many days can we give this Nasya?
Yeah, actually, Varanadi with Varanadikana, we are preparing the Shira Paga. So, Pradimarsha Nasya, Nasya, depending upon the condition, we can give. So, if the Marsha Nasya is given maximum duration, and before that, one Shodhana is necessary. Before giving the Mashanasya, we need to give a Shodhana, and after that, better. After Vamana, if we are giving the Nasya, it is very beneficial in hyperprolactinemia.
Okay, and Dr. Krupa Patel, she wants to know about some Ayurveda medicines which can be given to hyperprolactin patients seeking infertility.
Okay. So the hyperprolactinemia, of course, the patient, if she is infertile, she will be having ovulatory dysfunction. So our primary focus should be at the level of Agni. Because if the Agni is corrected, automatically all the things that is happening due to the improper Agni will be corrected. So if we are correcting the Jadaragni level, if we are correcting from the Jadaragni level, the Uttarottara Dhadvagnis will be corrected. Uttarottara Dhadus will be like that. Uttarottara Dhadus will be corrected. If the Dhadu Nirmana is proper, the prolactin itself it will clear as such. So Deepana Vajana and Agni Dravyas, if we are giving to correct, or Artava Janaka Dravyas, if we are giving, like if the medicine preparations based on Tila or Kulatha, like I told, Kulathadi Kasha is very effective. Then Kanashadapwadi Kashaya is very effective. Tilakwada, as such, we can prepare the Tilakwada reference is there. That one Anjali Pramana Tila we can crush, and with the Buddha we can prepare the decoction, and early morning we can take. So if we have a small amount of pipali to that potency will increase. So like that, if we are focusing on the Agni, almost all the female disorders, the gynecological disorders can be corrected. Here also the Rasadhattvagni imbalance is the main reason behind the manifestation of all these.
Okay. How to deal with young patients, galacturia, and with the normal prolactin levels where fertility is not the main concern?
Normal prolactin level and galacturia. Actually, I referred that thing. I didn't get any exact reason for why the galacturia is happening in a person with the normal prolactin level. And in modern side also, they suggest like conservative management is a better way. There is no particular treatment, and some are giving the bromocriptine like dopamine agonist and dopamine agonist and all to control this. And they are found. I just read like this is very effective in this normal prolactin level galacturia. But for us, I feel if she's having a normal menstrual cycle, it may be, estrogen, anyway, if the level of prolactin is there also, if the breast development, everything is under control of this estrogen, progesterone, everything. So if we are correcting that thing, like we can focus on the Agni level itself. the lady, usually these girls will be having a sedentary lifestyle. Kaphavartaka ahara sevana, if we are taking a proper history, usually these girls present with galactoria and all will be having a habit of food which is Tanya Vartaka, like full sweet items, Madrasida Dravyas and all are more prone to develop. So we will do the Nidana Parivarjana, like avoid that things, it may give us results, I feel.
If a patient comes to us with the infertility and having prolactin levels of around 38 to 40, so what should be our approach? That we should start the cabergoline immediately, or we should wait for Ayurvedic treatment, or what to do exactly? Means once she has repeated the test again, and
Yeah, yeah, yeah.
yeah. So at which level we should start the cabergoline, and what should be the dose? Or we wait for the how much time we can wait actually?
Yeah, actually, I am not that much efficient with the modern medicines, truly, because I am from Kerala now. Actually, I'm not at all practicing, but for this presentation only, I prepared all that things. But according to my reference for this presentation, if the level is 38 to 40 nanogram per milliliter, it's not that much raised. And prolactin, of course, has a diurnal variation, and the values will vary according to some physiological causes also. So we need to recheck the level, and definitely we can go with the Shodhana Karmas first. Anyway, we need to check. I mean, try with the Ayurvedic management like Samshodhana, especially Vamana and Nasya can be given, and still the patient is continuing the high prolactin level. Further investigation should be done because this is this multifactorial nature. So we have to find out the root cause and eliminate. So if it is due to some other growing tumors, because if the tumor is in small size, slightly compressing the pituitary stalk, so that may slowly there will be a rise. So we have to find out the actual cause and treat accordingly will be the good way to manage this condition.
Okay, thank you, ma'am. Dr. Smita Patil wants to ask, ma'am, your experience about Karpuradi Vati in case of watery or milky discharge from the breast.
Actually, I don't have any clinical experience with that drug. I didn't try with that. If you can share, because it's a conversation, I feel, madam, if you can share, that will be appreciable because I don't have any experience with the Karpuradi body. I didn't try with that.
Yeah, Dr. Smita Patil, do you want to give your insights? Okay, meanwhile, we'll take another question. Sometimes there is only watery discharge from the breast and prolactin level is normal in some patient complaining infertility. So, how to proceed in such cases?
So usually this water discharge, if there is no foul smell or discoloration, it's considered as normal in reproductive, this one. So if once it is infective or milky or with pain and all, we should consider. Otherwise, some water discharges is found to be normal. I just referred that thing and I got like that reference. So if they feel some pain during discharge or if there is a foul smell, then we need to investigate for any infection. Prolactin, because prolactin has no role in that, I feel.
Okay. What pathya we can consider in case of panchakarma if we are administering in hyperprolactinemia? So, as you said, we should avoid dugdha. So, and kshir vikara. So, generally we give dugdha pan, akanda dugdha pan in Vamana. So, other any other also kshir vikara we should avoid in this panchakarma.
Actually, Vamana is a Shodhana karma. So whatever the things we are giving, it's getting expelled out because that is to saturate the things now. Saturate the cells and then we are expelling it out from the body. So if we are giving Aganda the Duktapana during Vamana karma, it's not a problem. But if these Kshira products, all these things are Brahmana and nourishing in nature, and Kshira, the Samya, Siddhanta is there now. Kshira Vardhanam, Mamsa Vardhanam, like that. So it has a tendency to increase the prolactin secretion from the anterior pituitary. That's why better to avoid the milk products for a while and take the things which is Deepana Pajana and Lekhana in nature and every time Pathya Dravyas can be taken, just like Mudga, Raktashali, all these are Pathya during every time. Amalaki, these all things as fruits. And anyway, Mudga, Shali, all these things are Pathya during thing. Yava is also very good. But Goduma, I feel it's more nourishing, especially because now this Goduma is found to increase the milk production in the postnatal woman. So better to minimize the Goduma, but we can increase Yava.
Okay, thank you, ma'am. As we know that there are some drugs which interfere with the prolactin levels, as you told. So, are there any Ayurvedic medicines which also increase prolactin levels? Means, if we give like many times patient ask like Shatavari and all. So, is it good to give Shatavari or we have to avoid such combinations?
Yeah, that we need to further research work should be, because I searched no much studies available in hyperprolactinemia in Ayurveda, and I feel these Ayurvedic medicines, when we check a yoga, it is multi-systemic in action. A single action drug is or yoga is not at all available in Ayurveda. If we take some even a small kashaya yoga, if we are taking, it is acting on multiple level. So I feel Ayurveda drugs has a potency that will site specific action is there. I feel, and according to the body needs, I feel the acne will act according based on that. Because now when we take this Navanida in a constipating patient, that will loosen our bowel. Whereas if we take Navanida in a patient with diarrhea, that will harden our stool. So how it acts is very difficult, I feel, Prabhava. But definitely the medicines which we are giving during pregnancy, indicating especially during pregnancy, we need to take a caution because all are Brahmana and nourishing in nature. So better to avoid all that things which we are giving during pregnancy, I feel, but need to go for further research, because not a final comment on any medicine.
Yeah.
Uh, because single medicine is effective in all systems, and it
Yes.
has site specific action too. So,
Yes. Definitely. In males also, does it cause infertility?
pardon?
In
Males,
males,
yes, it causes, because there will be sexual dysfunction for males, and the hypogonadotrophic hypogonadism will be there in male. So definitely they will also suffer from this kind, because oligospermia also will be there. Because
yes.
follicular stimulating, anyway, that FSH, everything will be hampered similarly.
Yes. Okay, Dr. Smita Patil has commented that in young girls around 17 to 20 year in 2 to 3 cases with normal prolactin levels, she has tried with the Rasapachakvati and Karpuradivati and she got the results. So she's also reviewing and studying about it. So great session by you, she has commented. Any other
Okay.
questions? Okay, I think it's 9. So we should conclude the session. So I would like to thank again. So on behalf of Nima OBGY Society, I would like to express my gratitude to Nima OBGY Society Central Office Bearers, Dr. Kamini Diman ma'am, Dr. Priyanka Nakade ma'am, Dr. Vishnu Bhavani sir, and Dr. Rajesh Utani sir for the guidance and their support to conduct today's webinar. I would like to thank and extend my gratitude to our eminent speaker, Dr. Abha L. Ravi ma'am, who took time from her busy schedule and delivered such a wonderful lecture. Thanks to all NEMA OBGY office bearers. I would also like to thank Mr. Akash and Dr. Prajakta Patil ma'am for all the help and guidance for the technical support. Last but not least, I would like to thank from bottom of my heart to all the delegates for their participation. Without all, this webinar would not have been possible and successful. So thank you for all attending and hope you all have learned and gained immense knowledge from this today's lecture. So now with the due permissions of all the dignitaries, I'm concluding today's webinar. Thank you everyone. Good night.
Thank you for giving me this opportunity too. And I'm thankful to Kamini madam for calling me. Thank you so much. It was a very good experience for me. Thank you.
Thank you.
We can now end the meeting.
Yes.